first live case which will go to Sunshine Hospital where Mamoto Habara is doing a live with Dr. Selvamani and Vijay Kumar Reddy. Mamoto, we are with you.
Yeah. Hello. Very good morning to all. I am Dr. Vijay Kumar Reddy from Sunshine Hospital along with Dr. Habara and Dr. Selvamani. Dr. Habara and Dr. Selvamani are doing the case. I will introduce this thing about the patient details. Here is a 84-year-old gentleman. He is having recent inferior wall infarction. He is a known diabetic and hypertension. He presented with acute inferior wall MI. His vitals are BP was around 70/40 at the time of admission, and ECG showing intermittent CHB. We did, patient is having inferior wall MI, we put the TPA and IIBP. We did primary PCA of the RCA. And patient is also having LAD mid CTO heavily calcified lesion, that is JCTO score of 2. We planned for a staged PCI of the mid LAD. This is about the case details. Now I will hand over to Dr. Habara and Dr. Selvamani for the discussion. Thank you.
Yeah.
Can you show the case, Anjo?
Yeah.
Next slide. Yeah, so this is so last time CAG. So at that time RCA was so myocardial infarction, and so the LAD is total occluded, and so circumflex may be so little bit stenosis, so that so the patient was cardiac shock, and so they treated RCA completely. So next slide. So with IABP, and they treated RCA like that. So that is very completely treated. And so you can see, so there is no collateral from the RCA to LAD. And next slide. This is final. Huh? Yeah. So so this is about 1 month later. So that so I want to check the Shine from the RCA. So that at that time, last 1 month before, there's no collateral from the RCA. But so sometimes after the treated vessel, so some collateral has developed. So that so this is today's first shot of the our team. So this is the RCA diagnostic catheter. So you can see so some collateral is developed from the PD branch to the septal to the LAD. This means last one month back there's no possibility for the retrograde approach, but so this time, so of course antegrade approach is mandatory, but so if failed, so we can do the retrograde approach. And next, Shine.
Next.
And this is our cranial view. So that so when I see the septal branch, so two view is very important to focus to the RCA connection. So RWA caudal view is mandatory. But so the connection to the septal branch to LAD, that is RWA cranial view is very important. So that two view we checked. So from the RCA, so that the connection was so we can see. So good collateral. And so next one. And so after that we check this today's Shine. So this is just a little bit our cranial view. So this is a first shot. Okay, stop.
No, Habara, what do you think that basically it is an LED CTO? We could see a faint channel or some soft tissue. You can see it distally, and there is a small connection. That is what we feel. Even though you have a retrograde connection from the RCA, it will be a first choice will be an antegrade attempt. That is what here. Dr. Gerald Warner is there. He is Dr.
Yeah. Hello.
Hello.
Dr. Habara. I think what you demonstrated is very important. That when we don't see channel connections at this time of an acute coronary syndrome, we'll have to expect from such a large right coronary collaterals will be existent, and they will come back. It would be ideal to wait up to 2 to 3 months actually to have full collaterals visualization. But the collateral you demonstrated is a little bit unfavorable for retrograde because it's right at the distal cap, isn't that?
Yes. Yes, that's right. So that to confirm that, so bilateral injection is important because there is also antegrade flow is there because septal to septal. So you can see, so there is also antegrade injection. So we can see the antegrade little bit flow. That is not a channel. So that is depend on the septal collateral. So that which septal is RCA connection is we cannot confirm so that with separate angiography. So that to confirm that bilateral injection is important. But today I think that I can finish only the antegrade approach. So that this time is only the single axis. So that my consider about that. So if failed antegrade approach, I set up bilateral injection at the time. This is my today's plan.
Habara, actually your approach is actually antegrade. In that situation, your first plan is antegrade wire escalation, right?
Yes, that's right.
So first catheter, and can you just tell which microcatheter, which wire, for what purpose? Can you just tell that now?
Yeah. So next Shine. So I chose Caravel because for the backup support, Corsair is better. But inner lumen is smaller compared to the Caravel. And Caravel is a smaller one, so that backup is not so strong compared to the Corsair. But inner lumen is larger than compared to the Corsair. So that I at first we want to check the CTO entry the morphology, and if there is a channel or not, that is very important. So that's also chip injection image quality is very important this case. So that we choose Caravel at first, like this one. So this is a tip injection with Caravel, and this is a syringe. So about 3 milliliter syringe. So this is a hard one. So that brings us from Japan. Sorry, and I injected with this one.
3 cc syringe. Huh?
Yeah, it's a 360
Yeah.
syringe.
Salomoni, it's a 3 cc syringe.
Yeah. It's a 3cc syringe. A little bit harder to inject. You cannot inject it off very fast.
Yeah.
You'll have to slowly inject. It moves very slowly.
It is from
Yeah.
Japan. It's only a Japanese can inject. Huh?
I don't know. That is in Japan. It's a very common to tip injection for the retrograde approach. So we want to see the channel. That imaging quality is very important for the retrograde approach. So that at that time, we use this this syringe.
Dr. Selavini,
Yeah.
just want to ask a question. If you calculate the JCTO score, it will be 0. So it doesn't help as such, seeing the CTOs and calculating the score.
Yeah, you are correct. See, only learning thing in this is, I think let him finish. No, we have
No,
so
it is
many-
not the ceremony. The most important thing is actually, as Dr. Gerald Werner told, you may think that there is nothing is the filling up. When the RCA is actually opened up, you are seeing collateral from the left side, right side collaterals are very good. At the same time, it is interventional collateral is a question mark. Number 2, according to Habara, it is a simple case for him for an antegrade approach because he is seeing a soft tissue channel there is easily to track and get it into inside. That is why he is, I don't know which wire he tried to use.
No, we'll hear it from him.
Yeah,
and,
that is what
we'll-
we wanted to hear from him.
He was very
Habara,
meticulous and he's very, although it looks very simple CTO, the care what he took and the result what he has got is excellent. We'll hear it from him and then probably we'll discuss the procedure.
can you tell Habara which wire, why?
So that we can see maybe some channel, but important issue is which angle is best to negotiate the wire. So that we check the aerial cranial view. But so this is the area of cranial view is not so good. So because so that is very tangent, so we cannot see the so CTO segment. So and the next, and so we check the so I will code our view again. But so this view is not so good. So that so we have only had so epicranial view. And the next. And so at first so XTR I chose. And so XTR can go to like that. You can see. So there is a so septal connection so that so we can see the distal end. But so that XTR can negotiate it to the so distal end. But so distal point is so hard, so you can see the wire prolapse to the so diagonal branch like that. So next, I cover the portion with the so caravel. So next slide.
Next you move.
Like that. So that wire is so prolapsed. So that so I negotiated to cover that point so with the caravel. And so next. But so XTR cannot advance. And I change it to the so another wire. So can I talk to this?
Yes.
Okay, and so I selected so Gaia next one. So that is almost similar to the so Gaia series. I recently in Japan I changed it to the so Gaia next, so that I changed it to the so Gaia next one. But so even though so I use so Gaia next one, so
Actually, we don't have Gaia next here.
yeah.
We have only Gaia 1 and 2. Pratap, do we have Gaia next?
No.
We don't. So he used that wire, Gaia next 1.
Yeah, but it's the same. So that so I push it so Gaia next one. The guide wire is prolapsed like that.
Yeah.
Can you see this? So I advance the so guide wire micro cache it is a little bit pull back, and so like that, so that wire is prolapsed. That means so distal portion is so hard, so that so Gaia next one is too weak to penetrate the region. And so another point is so guiding catheter. So I negotiated the so guide wire advance, pull back the so microcatheter, and so also guiding catheter is also pull back. This means that so distal portion is too hard. So next step is so guide wire escalation. So that point is so hard, I change it to the so Gaia next 1 to the Gaia next 2. And maybe this is a Gaia next 2. So Gaia next 2 go to the so another route. And that next.
Next.
Yes, next. So this third portion is a little bit hard, but so slowly advance, so like that. So guide wire go a little bit to advance to the so this third. And the next. And we check the shine.
So do you think it's okay here?
No, I think in this time, why don't you check with the right injection and understand that exactly you are in the lumen or not? Habara, that should be the ideal one, right?
Yeah, that's right, that's correct. To confirm that so that is true or not. So the exact answer is so that is true. So RCA injection, that is so very important. But so today, so I only set so only single approach, so that the next we check the shine.
But
so a little bit, so guide wire is so subintimal space.
Dr. Habara,
Yeah.
once you are in this position, you from the previous angio, you would have already reached beyond the distal cap. So
Yeah.
actually, the wire should give you the feedback whether you are free or not.
That wire is looks free, but also like that, so guide wire movement is not so good, I think.
So maybe you need a second axis now for confirmation of the distal.
Yes, that's right. But so this case has a so septal connection, so that so we can see the distal landing, and so that one point is so at this point so another access and confirm the angio and parallel wire technique is so one answer, one choice. But so I think that so entry is not so bad. I think that so the guide wire is very looks so very close to the distal end. So that is anyway one time I reroute the wire to the so left side at this point.
Then next.
And next.
Next.
Actually, Salomoni, whether you have to continue with this one or we have to go to the other lab and come back, or
Yeah, just give us 5 minutes, we will cross it. And it's already, we'll show you next you go.
okay.
Yeah, next. See, now look at this. What we did is he just withdrew the wire back and then tried to manipulate it. The wire went into the true lumen now. Now it looks very freely moving and it is going down there. And with this Gaia next to 2, we
Yep.
crossed this lesion and we reached the distal segment. Next. And now after this, the very important thing was to prepare. Next. Anything else from at this point now? Would you like to take the microcatheter inside and change the wire, or you want to do something here?
If the microcatheter can go distally, it is okay, but by the distal lesion, if it is a tough lesion, I think it will not be easy to go.
We tried to push the guide microcatheter, it did not go. It was backing up, so he removed the microcatheter and he took a one-size balloon and dilated with the balloon. And after the balloon, he again put the microcatheter inside and then changed it to the next wire. Next. From this Gaia next to 2, he changed it to. See, this is what the microcatheter. One more thing, what I observed is, after putting the microcatheter there, even there you gave a tip injection and confirmed that it is in the lumen, but which we don't usually do. But he is very confident in doing that. And,
No. Basically, because he does have only one access now. Habara, because it is
Yes,
only,
sir.
that's the point. There is no way actually. He wanted to confirm it because it is one
Confirm it.
access. Or
So that is what he did.
no,
He
any
did-
other comment? Dr. Werner wanted to make a comment.
No. I think it is because there was no real depiction or delineation of the distal vessel. Is there other lesions? So that was important to have information about the distal anatomy, which we didn't get from the very faint collateral filling.
Correct. Okay. That is also an important point probably. Next. And then he changed it to a cyan blue wire and prepared it with 2.5 balloon. And now it was prepared and there was a flow established there. Then there was a question now. Do you want to directly stand, do some imaging, or if at all doing some imaging, what you want to do? And finally, we did an OCT in this case here. And any comments from the panel there regarding the imaging strategy for this?
I mean, we say that OCT in CTOs is not favorable when you have dissection, but this seems to be a straight wire passage with not much false lumen, so I think contrast injection is okay.
Yes. That's
See,
right.
basically, even in an OCT, what I do is, if there is a good flow, and then we prepare that lesion adequately. Many times what happens is, if you don't prepare it with a bigger balloon, at least 2 or 2.5 balloon, you may not get a good distal flow and it will be difficult for an OCT there. But here what we did is, we prepared it with a 2.5 balloon and we have done the OCT. Can you see the OCT images there? And we have Dr. Partha Sarathi here, who did a beautiful OCT injection, and then we got an excellent recording of OCT. And it was a hand injection that what we do. But in our center, basically we do power injection. But here, it was a very good hand injection and a very good clearance and good image what you have got here. Now coming to the analysis now, when you look at the distal vessel, so we searched for the landing zone there, so we could see an area here which was measuring 3, the TL to EL was 3 mm there, and then just came up. And when you come up, it was all predominantly a fibrotic lesion. On angiogram, we were seeing a lot of calcium, probably all it's an external calcium, where it is above the diagonal. But below the diagonal, it's all predominantly fibrotic area. And one more interesting thing that what I would like to tell you is, we had a wire crossing into the intima and going out and coming. So when you see the OCT, you can make out which way the wire had crossed. See, many times if you leave the wire there and then do an OCT, you can see the wire going into the intima and coming. And many times we have seen that OCT catheter being in a false lumen also, which helps us in selecting the proper lumen to stent in the case of CTO. So here you see that there is an intimal wire crossing which has gone and entered there, but we have removed that wire in this case. And that's not a big difference in the treatment aspect today now. When you come up, it's all predominantly fibrotic lesion. And but near the diagonal, there is some amount of calcium, deeper calcium, which should not really cause any problem. And when you come above the diagonal, come up above the diagonal, there are circumferential calcium. And at the diagonal, you see that the angle between the LAD and diagonal is almost 90 degrees. And the carinal branching point to carina, the distance is also very good. And there is no big calcium opposite to the carina. So then the possibility of closing, that is this diagonal closure possibility is very low. So if you want, you can wire it or leave it. But Habara wanted to wire it and keep it safe. So he has wired it. Then when you come up, it's again a circumferential calcium above the diagonal. But nothing, lumen is very good there. But it's all a deeper calcium there. So now on this imaging, we were very, very sure that the distal landing zone is 3 millimeter EL, predominant fibrotic lesion up to the diagonal, and above the diagonal it's a calcified lesion but deeper calcium with a lumen area above 4 above the diagonal. So now the strategy is you want to prepare this lesion. Like if Pratap, if you were there, what will you use for preparation, or will you take a stent now?
I did not see that.
Okay, anybody from the panel there?
No, I think there was not much calcium, so I think you should go ahead with the stent.
Okay. So what we did is, actually we had prepared with a 2.5 balloon, and we know that EL is 3. So we thought we should get some more expansion. We used a cutting balloon, 1:1 ratio. That is, we used a 3 cutting balloon there below the diagonal and expanded it with it. And after doing that, our length of the lesion on OCT is very clear. It is 38 millimeter, and distal landing zone is 3 millimeter, and proximal luminal area is 4. So we were very clear. We will take a 38 millimeter stent there, land at those angio-co-registered spot that what you are doing, and we landed there. Habara landed it perfectly like that. You can go to the next angio.
With the angio co-registration, what are the problems of Habara landing a stent? It will be easy, you know. Otherwise also he would have landed. Yeah. Habara, actually, what are the situations where you use OCT in CTOs? How many cases and what are the usage?
This is first time for me, so to use the OCT.
So that is why Salomoni is scoring over.
No. Actually, when we discussed, actually he took a 8 French guiding, saying that we will use an IVAS guided puncture, IVAS guided wiring, and but probably then OCT and CTO is always, many people are not comfortable. So I made him that we will do an OCT, and this is what we have demonstrated now.
No, it is wonderful. You know, people should see that this modality is useful in CTOs also. But I'm just telling, especially after crossing the lesion, not before crossing the lesion. There are some studies happening that even for OCT guided puncturing, Habara, in Japan only it is happening, right?
No.
One fellow presented a publication when I was in CTO Plus in US. I don't think that is from Japan only.
Yes, and especially so in Japan we have another IVAS, so that Telmos one, so that is the most popular to use in the CTO procedure.
Okay. We have to go to the other lab, and you have to finish by another 3 minutes maximum.
I think we will explain it.
Okay, please go.
We will not come back to you after that.
Okay, we'll finish out. So what we did is we took a 3.8, 38 into 3 into 38 Zine stent there and deployed above the diagonal and there and post-dilated with a 3 NC balloon below the diagonal and 4 NC balloon above the diagonal. And what we could make out there is next. In the post-stenting procedure, so this is the post-stenting OCT, that what we have there. And it's a well-expanded stent. Distal to the stent, there is no dissection. And it's a well-deployed stent without any dissection come up. And it's well-expanded. When you come to the proximal segment, above the diagonal and around the diagonal, you keep watching, there are certain areas of malapposition. This is at the diagonal, and this is at the proximal segment. There are certain areas of malapposition. Basically, when we are placing a NC balloon there, because of the calcium, we were not sure about the stent. That is why we did not keep it properly there in the proximal segment. That is what I feel. And after that, we have repositioned it and dilated with a NC balloon and made a good apposition here. And this is the final there. You look at the diagonal, absolutely no compromise, and it's a well-flowing diagonal wire there. And on 3D, you can make out there are some struts across the diagonal ostium there. And, but I don't think that's a problem here. We did not put a wire recross that. Dilatation is not there. Only in left main probably we'll have to worry, but here in the small diagonal, we can leave those struts across the side branch and then come out. And I think it's a very meticulous CTO work that what I had an opportunity to observe here and learn from him. And this is the OCT final image with good expansion without any complications. And
the final cine?
And the final cine you can show there.
Habara, did you do a dilatation with the 4 millimeter balloon later? Okay.
Yeah, it was at the 4
Yeah,
millimeter.
it is 4 millimeter, yeah.
So we will actually take the comment from all the panelists, starting from, can you just give a comment on this case?
So number one, a simple contralateral injection from right, I mean, maybe reducing the time by 10 to 15 minutes, where number one. Number two is dilatation with 1 millimeter balloon without, I mean, knowing whether this is in a true lumen and false lumen, maybe some adventurous thing.
He was actually almost sure that the wire actually jammed like that. It is actually the wire movement by the
Yeah.
tactile sensation. He understood he is in the true lumen, no doubt about it. That's not his and the bilateral injection was ideal. He was planning for a single one. Dr. Manu?
Yeah, imaging definitely helps to find out the size of the lesion. If we are not used the imaging, we will definitely take a 2.75 stent. Here, we are taking a 3 millimeter stent and proximal part dilated with a 4 millimeter balloon. In the middle area. So imaging definitely helps in this OCT lesion because
So
chronic
the 4
total
millimeter
occlusion.
balloon usage is basically because imaging. Otherwise, you could have stopped by 3.5 millimeters.
Yes.
Gaurav, any comment?
Sir, when the wire got stuck in the subendothelial space, how frequently he uses the parallel wire technique for this?
No, if that was there, he would have definitely done a parallel wire
Because
technique.
he upgraded.
Probably it is actually totally true luminal. Correct, Habara? It was totally luminal, right?
Yeah.
Totally luminal. There is no question of it is parallel wire technique. And it's only that tough CTO segment in the distal entry point. That was the only point.
Yeah. So that the wire is almost located at those distal portion. So that the main point of this case is just penetrate. So that and anyway, so if I remove the guy next to, so that at the time, so I consider about the parallel wire technique with the double lumen catheter and guy next to 2 and guy next to 4. And so at that time, I can set up bilateral injection. But fortunately, so guy next to 2 removed succeeded in this case.
Thank you.
That's
And
yeah.
Dr. Ashokan?
Excellent case and well demonstrated the role of OCT and the newer generation of the Gaia and the bifurcation lesion managed very well. And the message is tip injections may be only in distal if it's a lumen, otherwise to avoid it. That's also is.
Dr. Verma?
Excellent case, probably very simple for Dr. Habara, but for the average operator, it could be a tough case because what appears simple on an angiogram might often turn out to be really tough. Bilateral injections, probably, yes, most of the operators should still probably use bilateral
Actually, that is a
injections.
basic concept. When you do CTO, never take any CTO as a simple one. It is actually, it can turn out to be complex. So we should be careful of having bilateral injection. Any comment?
Case beautifully done at the onset. The distal and proximal and distal mismatch looked quite frightening, but very well managed, and imaging helped us because without imaging 3.5 proximally at high pressure, and most of us would have been happy, but imaging showed us that we can go up with a 4 to oppose the stent completely. Thank you.
Actually, Habara, it was a wonderfully done case. Actually, Habara looks very young. He's looking like a 20-year-old man. He's a very senior, experienced guy. He is a Toyohashi Heart Center, one of the largest heart center doing the maximum CTOs in Japan. He is actually the co-director there, and he's actually a friend to us. And with a short notice, he has to attend two live case demonstration tomorrow in Japan. Because of my pressure only, he came here. And thank you, Habara, for joining with us. And thank you very much for the wonderful display of a CTO segment. Thank you very much, Sunshine Hospital. Selumani showed how imaging can help us in CTO, even OCT, how OCT can do wonders in this thing. And all the team of Sunshine, we are thanking you, and all the people we can see. Ram, that fellow is standing behind the Madurai guy.
This is Dr. Parthasarathi.
Yeah.
And a very beautiful team here in Sunshine. The entire team is very cooperative and very good.
Thank you. It is a hospital run by Sridhar. Sridhar, naturally, it should be.
We should thank Sridhar Kasturi and Dr. Vijay Kumar for this
Thank you.
wonderful.
Thank you. We will go to the next, because Surya Prakash is waiting. Thank you very much. We will go to the next, the switch over to Dr. Surya Prakash.